All right, good morning, everyone. It's so great to see you on day 2. This is our last mile. We're going to pull everything together that we talked about yesterday. We are starting a little bit earlier than yesterday, so we can get off to a great start. It's my pleasure to introduce our moderator for the first session this morning, Miranda Klassen, who you heard from yesterday. So I'm going to turn things over to you. The full bios for our speakers are online and in the program. So just in the interest of brevity, we'll keep the introduction short, but we know how fabulous all of our speakers are. We're happy to have them. Miranda?
Good morning, everybody. It's another great lineup, many wonderful speakers that I'm sure you're so excited to hear. The first speaker we have today is Dr. Brian Bateman, who is the chair of the Department of Anesthesiology and Perioperative and Pain Medicine at Stanford University. And he'll be talking about how, I love this title, anesthesiologists can move the needle. I'll be followed by, I believe, Dr. Bauer, yes? Good morning, Dr. Bauer. Coordinating in the community to decrease serious postpartum morbidity is what Dr. Bauer will be speaking about. She's a DO, which I love. She is the Associate Professor of Anesthesiology and Population Health Sciences at Duke. Also followed by Meg. I love that you abbreviated your name. Meg Rosenstein. Did I say that right? Awesome. The Associate Chief Medical Officer and Director of Obstetric Anesthesia at Overlook Medical Center in New Jersey. And she'll be talking about how community practice has implemented bundles for improved quality metrics in OB. And then lastly, we have another special guest, two sides of the coin, enhancing maternal and pediatric anesthesia safety in Japan. Dr. Yasuko Nagasaka, who is the chair and professor of anesthesia at Tokyo Women's Medical University. She's double boarded here in Japan and the United States. So please let's give everybody a warm round of applause and Dr. Bateman.
Thank you for that introduction. It's a pleasure to be here and to be part of this panel. So over the next 15 to 20 minutes, I'm going to make the argument that we as anesthesiologists, given our training, given our skill sets, given the way that we work on labor and delivery, are uniquely positioned to move the needle, obviously in close collaboration with our obstetricians and our nursing colleagues, but to move the needle on maternal safety. But to do this, and really to maximize our impact, we need to reconceptualize our role and the scope of our practice on labor and delivery, and the scope of the responsibilities that we take on. Jill Meyer, who's here as well, and I wrote this editorial in Anesthesiology about 10 years ago now, where we were commenting on a paper that showed, using population-level data, a really substantial decline over time in anesthesia-related maternal morbidity. And we saw data yesterday that anesthesia-related mortality has dropped to almost negligible levels. But at the same time, the paper showed what we've seen in other data sources, a rise in maternal morbidity and mortality. And so in this piece, we called for anesthesiologists to move beyond providing just safe anesthesia and analgesia for labor and cesarean, and to really embrace the role of peri-delivery physician. I think we were the first to sort of coin that term, and really drew on all of the discussion of perioperative physicians that was happening at the time. And we made the call for anesthesiologists to step up into that role on labor and delivery unit, and I think that call is as relevant today, perhaps more so than it was when we wrote this 10 years ago. When you think about our training as anesthesiologists, we do a full year of internship in medicine or surgery, where we get a lot of exposure to managing complex medical patients. As part of our training and residency, we do 4 months of ICU. And if you contrast that with obstetricians, they routinely do a couple of months of medicine during their intern year and 1 month of ICU. They obviously have a lot they have to learn over the course of 4 years in obstetrics, gynecology, how to do surgery. So really coming to this position in our training, we are the ones that have experience in the management of critically ill patients. And of course, outside of OB, we routinely take care of patients in the operating rooms with the comorbidities and complications that are some of the leading causes of maternal morbidity and mortality. We care for patients with complex cardiac disease, patients with bowel perforations that have sepsis, patients that hemorrhage during a liver resection. That's part of our daily job in the general OR. And that I think really generates a lot of skills that are quite transferable to labor and delivery in ways that help us take good care of critically ill obstetric patients. So I want to look at this question of the role of anesthesiologists as peri-delivery physicians at 2 levels. And the first is really asking the question, how can we lead locally as peri-delivery physicians? And as I talk about this, I'm going to describe a number of QI projects that I've been involved with, always in close collaboration with obstetricians, where I have really tried to realize, along with my colleagues, this vision of anesthesiologists as peri-delivery physicians, and I'll explain what I mean in the coming slides. And then in the second part, I want to zoom back and take a look at how we as anesthesiologists can lead in a broader way, and how we can scale our work for impact and lead, again, along with obstetricians and nurses, can lead regionally, nationally, or even internationally. So when I think about the role of anesthesiologists as peri-delivery physicians, I really think about 4 different categories or 4 different elements. The first is presence, the second preemption, the third proficiency, and the last platform. And we'll talk about each of these in turn. So we think about presence. We as anesthesiologists are often on labor and delivery units 24/7 at many of our hospitals, or at least we're immediately available to labor and delivery, which positions us to respond immediately in cases of emergencies. We can be there at the bedside immediately to help manage deteriorating patients. Our presence on labor and delivery, as well as our presence in the operating room if patients go for cesarean delivery, allows us the opportunity to longitudinally monitor patients and to be present at really critical points for maternal safety through the period in the labor room, in the OR, and into the postpartum period. So an example of a project, a QI project, that really leverages our presence is this work that was done at Stanford, led by Jesse Ansari and Natalie Coons and a bunch of other folks you see listed there. This was published in Anesthesiology, I think just last month. And it builds on work that we did at the Brigham, where we validated a 10-point, or 11-point rather, numeric scale, so a scale of 0 to 10, where we asked nurses, or asked the obstetricians at the time of cesarean delivery to palpate the uterus and rate the tone of the uterus on a scale of from 0, meaning no tone, to 10, meaning really robust tone. And we showed that in the study at the Brigham that this had good inter-rater reliability and correlated with blood loss. So building on that work, the team introduced into EPIC a tool that prompted the anesthesiologist to chart, to ask the obstetrician, and then to chart at a time point of 0 minutes after delivery, 5 minutes, and 10 minutes, the uterine tone. So just to squeeze the uterus and say what the tone score is from 0 to 10. And the analysis of the data that collected is that there are hundreds or even thousands of patients that were involved in this quality improvement initiative, showed that if a patient had a score of less than or equal to 6 at 10 minutes, the probability of having significant hemorrhage, so a QBL of greater than 1,500 cc's was 1 in 3. Transfusion was 1 in 5. So I think the strength of this work is it really shows that at a very early time point after delivery, you can get a good sense of the trajectory that the patient's on. And if tone score is 6 or less, you're in a position where you should be thinking about obtaining extra IV access or potentially ordering blood. Now we're looking at ways of creating bundles that allow us to respond. So if the patient has a low tone score at 10 minutes, to make sure they're getting a second-line uterotonic, to make sure that we're doing all the things like administering tranexamic acid, all the things that we need to respond to a hemorrhage. And again, this is leveraging our presence on labor and delivery, our presence in the OR as a way to improve patient safety. So the second P is preemption. And really the notion here is that we have the opportunity to meet patients early, sometimes before they even come for delivery, as in part of an antenatal consult, anesthesia pre-op, and can help work with the obstetricians to optimize the patients and come up with pre-delivery management plans for the patients. Preemption also relates to screening for high-risk patients and using our medical knowledge and our skills in evaluating patients to develop systems that allow us to identify the highest risk patients that perhaps deserve some extra attention. And then the opportunity to intervene early when we identify high-risk patients to prevent deterioration. So this was a project that, data from a project that was led by Sarah Ray Easter, a maternal fetal medicine and ICU physician at the Brigham. About 15 years ago, I, working with Jill Meyer and several others, developed an obstetric comorbidity score using claims data that was really designed as a tool for epidemiologic research, for adjusting for patient comorbidities in health services or clinical research. And Sarah Ray had the idea of, well, can we bring this into routine practice on labor and delivery as a way of putting the spotlight on our highest risk patients? And so we adapted the score for use in clinical practice. The way we implemented it is the nurses calculated the OBCMI, which is basically a weighted score of a bunch of comorbidities that increase maternal risk for severe maternal morbidity. And then the nurses reported the score, so they would say, Ms. Jones in room 5 has a score of 6, and that's based on the following comorbidities. And really the idea is that this would create a heightened awareness of high-risk patients and prompt conversations that could occur around management plans. And when we did a prospective validation with adjudicated cases of severe maternal morbidity, we were able to show that each point of increase in this score increased the risk of severe maternal morbidity by 55%. The C statistic was 0.83, which is quite good for a risk assessment tool. And this has now become a routine part of practice at the Brigham. Even to this day, the nurses report out the OBCMI when they do multidisciplinary rounds. I think there's a lot of work to do to explore whether this approach can be brought. I was talking to Elliott yesterday. He's exploring using a scoring system early in pregnancy as a way of identifying who might need a consult from a maternal fetal medicine specialist or who might need referral to a tertiary quaternary care center. I think there's a lot of work that still needs to be done to show the impact of this kind of an approach on outcomes, but I do think it's a nice example of how we can think of ourselves as peri-delivery physicians and really act in that capacity to identify high-risk patients and hopefully preempt patients who are high risk from having complications. So the third P is proficiency. And here what I'm thinking is the idea that we as anesthesiologists are critical care leaders. We have the role on labor and delivery of guiding resuscitation, guiding massive transfusion, helping the obstetricians with complex comorbidity management, leveraging our experience in acute pain management to provide pain management direction. And I'm going to provide an example of a QI project that really leverages our expertise in pain management on the next slide. And then procedural excellence, our ability to manage the airway, to obtain vascular access, to do POCUS. That's something that's become an increasingly important part of the practice of OB anesthesia, and then obviously regional and neuraxial anesthesia. So this was a quality improvement project done in collaboration between OB and OB anesthesia at the Brigham when I was there as division chief. And there's a fairly robust set of epidemiologic data showing that opioid exposure following delivery, either following vaginal delivery or cesarean delivery, is linked to persistent opioid use and in a very small proportion of patients to opioid use disorder. We also know that when patients are discharged with a large amount of opioids that they don't use, that is a really important source of opioids that are available for diversion and misuse. And with cesarean delivery or vaginal delivery, where opioids are not infrequently prescribed, being some of the most common indications for prescribing of opioids at the population level, this was a really important issue to try to tackle to rationalize our use of opioids in this population. And if you look at Europe, opioids are not routinely prescribed after even cesarean delivery. So leveraging our expertise in analgesia, we put together a group that thought about, okay, what would be sort of an optimal approach to pain management in our post-C-section patients? And we thought about the dosing of Duramorph in the spinal or epidural. We created an order set that had the administration of scheduled Tylenol and NSAIDs. And then we eliminated the routine ordering of opioids after cesarean delivery. So opioids, we switched the framework from opioids as being sort of the primary approach to analgesia during both the inpatient and then following discharge to something that was prescribed as a short course when necessary as a rescue medication. And you can see some of the key results from this study in this figure. The orange bars represent our practice prior to the intervention. And you can see 90% of patients were discharged with opioids, often quite substantial amounts of opioids, 40 or 50 tablets of oxycodone 5 milligrams. And after we did this intervention, the proportion of patients discharged with opioids was less than 40%, and most of them who were discharged with very short prescriptions. But interestingly, when we surveyed patients after this pretty dramatic change in practice and this really massive reduction in the use of opioids, about the proportion who were satisfied with their pain control, we achieved similarly high proportions with approximately 90% of patients in both instances reporting being satisfied or very satisfied with their pain control. So again, leveraging expertise in analgesia that from acute pain management and bringing that to our labor and delivery units. And then the final P that I want to talk about is platforms. So our roles as key figures and key leaders on labor and delivery units. And here I think it's really important that we as anesthesiologists own standardized care pathways and order set defaults and really work with our obstetricians to drive quality improvement and maternal morbidity and mortality reviews, and to lead simulation and debrief culture. And we had some wonderful talks yesterday about that, and I trained at Mass General, where Pian-Smith was really deeply involved in leading simulation along with our obstetrical colleagues. And I think that's a nice example of us embracing the role of peri-delivery physician. And so just a couple of examples of, again, this is work drawing on my time as division chief of OB at the Brigham. When I was there, we, in partnership with the obstetricians, instituted the ACOG SMFM approach to screening for severe maternal morbidity. So any patient who went to the ICU or who received 4 or more units of blood was reviewed on a monthly basis. We all sat around a table, so a bunch of obstetricians, a bunch of anesthesiologists, a bunch of nurses, and did detailed reviews of all of those cases to assess for care quality and to identify opportunities for improvement. And I think this would only really work with all of the constituencies on labor and delivery, the anesthesiologists, OBs, midwives, nursing, coming together, thinking about how we could potentially avoid some of these complications. A second example of this is the hypertension order sets. So Sebastian Seifert, who's a member of my division, made the observation that a lot of patients who are coming to the Brigham, a place that is really well-resourced and has really a culture of obstetric excellence, there were a lot of patients who came in with severe range blood pressures where the time to treatment was in excess of the recommendation of an hour. And we heard yesterday from Elliott how this is likely to be a joint commission measure. And we found there's actually a minority of patients that came in with severe range pressures that were getting appropriate therapy within 60 minutes. So Sebastian worked on creating an order set and developed a streamlined process for ordering and pulling medications that allowed the nurses to obtain the medications more quickly, as well as gave the nurses the ability to, without additional orders, to titrate doses. And with these interventions, we were able to really dramatically improve the time to treatment for severe hypertension. So thinking about this issue of how we can lead locally, again, I think really embracing the role of peri-delivery physician, thinking of ourselves as more than just the people who place epidurals, who provide anesthesia for cesarean deliveries, but embrace these concepts of presence, preemption, proficiency, and platform to expand our impact. To do this, we obviously need to team up with other safety champions on our labor and delivery units in our hospitals to optimize patient safety. And then as we do these interventions, I think one of the lessons learned is that it's really important to hardwire these. A number of the things I described were involved building new order sets in Epic, implementing tools in Epic that prompted people to report scores so that the interventions really stick. And then, and this was a theme yesterday, create a system that's constantly learning, where you're reviewing your cases, identifying areas of opportunity for improvement. So I now want to zoom back a little bit and talk about being peri-delivery physicians at scale and thinking about our role as anesthesiologists in contributing to maternal safety at the state level, the regional level, the national level, the international level. And the first place I think there's real opportunity for us as anesthesiologists is on serving on maternal mortality review committees. Elliott talked about this yesterday, but relatively early in my career as an attending in Massachusetts, I was appointed to the state maternal mortality review committee. And I found in that work, I was really able to bring a pretty unique perspective. I think I was put on the committee to be able to opine on anesthetic management of some of these cases, but our understanding of critical illness, of substance use, of pain management, I think creates a really unique lens that allows us to contribute to the thinking around these cases of maternal mortality and the types of opportunities for improvement that could be instituted at the state level. Participation by anesthesiologists has been promoted by ASA and other societies, and I think that's something where the APSF could really lead in making sure that all of the states around the country have an anesthesiologist that are part of this process. It's also important that anesthesiologists engage in state quality improvement initiatives. Again, Elliott mentioned yesterday the role of anesthesiologists in CMQCC and in AIM, and I think we're, as a critical member of the care team, we need to be at the table and involved in helping to create the bundles that impact on patient management. At the national level, I think there's a lot of opportunity for leading in the writing of multidisciplinary guidelines. Lisa Leppard has been a key leader in this and in VTE guidelines. This is this consensus statement that I show here was led by Grace Lim. And was really, I think, a nice example of obstetricians and anesthesiologists coming together. So we put together a group from SMFM, from SOAP, from ASRA, and generated pain management guidelines for patients with opioid use disorder. And then we were able to publish these guidelines that were, the lead author was Grace, in both Anesthesia and Analgesia, as well as in the American Journal of Obstetrics and Gynecologists, so able to reach sort of key audiences. But this is an example of an anesthesia-led, but really multidisciplinary piece of work that I think really helps improve the management of a very challenging patient population. The third way I think we can lead as anesthesiologists is in research. And our background in pharmacology and pathophysiology, I think uniquely positions us to do really impactful research. As we embrace the role of peri-delivery physician, we really need to move beyond the bounds of traditional OB research, looking at ways to optimize our labor epidural dosing and mix and the approach to providing anesthesia for cesarean delivery, and really work on the most pressing problems in maternal health. And I've been really happy to see a number of examples of obstetric anesthesiologists, Grace Lim, Pervez Sultan, Jesse Ansari, really working on problems that are bigger than what has traditionally been thought of as anesthesiology research, and that's led to NIH funding to do really impactful work. I show here a paper that Brenda talked about yesterday that we published in the New England Journal a couple of years ago, where we compared buprenorphine versus methadone for the treatment of opioid use disorder. And this work was really deeply informed by my background as an anesthesiologist, thinking about the pharmacology of buprenorphine and methadone. And I really don't think we could have done the same study without the perspective of an anesthesiologist being part of this work. So I think we need more of that, more anesthesiologists that are bringing the unique lens that we have around patients and critical illness pharmacology, pathophysiology, to important maternal health questions. So May asked me to close out my talk by talking about some key questions for the breakout sessions, and there have been a number of topics that have been identified that we'll be discussing and hopefully coming up with some recommendations around. And what I challenge us to do as we think about these issues from a local perspective is really look at it through this lens of the 4 Ps of anesthesiologists as peri-delivery physicians, and how each of those categories could be applied to the questions that and the topics that we're being asked to discuss. And then as we think about these issues through a broader lens, we should think about where and how anesthesiologists should lead. What are the priorities for guidelines? What are the priorities for our research agenda? And then to really think strategically. So what should be our broader strategy as a specialty to move the needle on maternal safety? And then concretely, what are the next steps tactically? How are we going to start to get this done? So thank you so much for your attention, and I look forward to our discussion questions later. All right.
Good morning, everyone. Thank you so much for the pleasure to be here today. Let me just get my timer started. So I like to talk, so I want to make sure I stay on time. We're going to go through reducing maternal morbidity and mortality through shared leadership with patients and community. I do want to acknowledge that this work was funded by the NIH, but anything that I express here today is not necessarily the official views of the NIH. We'll go through the project summary, then we'll talk about community and patient engagement broadly. Then we'll go through how we work together to improve the key delays that led to maternal deaths from sepsis, and those are delays in recognition, treatment, and escalation of care. So let's get started. This project was grouped into 2 phases. The first part was the planning phase. And so this was our opportunity to identify the barriers to care for patients, and then also identify the barriers to implementation from the provider side. And the way that we did that was we did qualitative work where we interviewed patients who experienced maternal sepsis, and even interviewed family members if a partner had died from maternal sepsis, and looking at quality improvement opportunities there. Then we also interviewed providers to determine what were the barriers to implementation. So why weren't they implementing the sepsis bundle that we had created in 2020 with CMQCC, and also the bundle that we had created with AIM. And then we also took that time to refine our screening and diagnostic criteria for sepsis and pregnancy. But most importantly, this phase was to create strategies to address these barriers. With any implementation, if we don't address the existing barriers that are already there, you're going to have implementation failures. So we need to work to reduce those barriers before we even get started. So that was the first phase. The second phase was our implementation phase. We worked to implement the sepsis bundle throughout all birthing hospitals in the state of Michigan, and in California they did a small subset with plans for the rest of the state. And we had mentorship teams meet with hospitals every single month to go through what challenges that they were facing, help them troubleshoot, give them resources, give them some education as well. And we had followed the plan that CMQCC had done for many, many years, which was have a nurse and a doctor meet with hospitals monthly to talk about these things. Well, we thought it was really important that we provide that community and patient voice as well. And so for the first time, we included a community leader as well as one of the coaches. And then we also included a consultant with lived experience, so someone who is a maternal sepsis survivor, to give them that perspective as well. So that's the overview. How did we start? So before we did anything, we thought about how we could make the most impact with sepsis. And we thought about that if someone carries to full term, they're pregnant for 280 days, they're in the hospital for 3 or 4 days, and then postpartum for a year. And if we only focused on that hospital care, we would miss a really important opportunity to affect maternal sepsis, because people don't live their lives in a hospital. So we wanted to work throughout that entire time period, and the most important way to do that is to engage your patients and your communities in doing that. So we wanted to follow all of the important principles for patient and community engagement, and this is an approach that involves partnership and power sharing and decision making that is many times in combination with, but sometimes there's some decisions that they're going to make that are really important for their communities and patients. And it's really doing research with people that the research will actually impact. And so the first thing that we did before we did any research activities was recruit the Maternal Sepsis Community Leadership Board. And Kendra Smith is the liaison for that. We tried not to use leaders when we're working together because we didn't want to create power differentials, but Kendra Smith has a PhD in community engagement, and she worked with us, and we worked together with her to make sure that we were following all of these principles for appropriate community and patient engagement. And so we recruited a number of members, mostly members in Michigan and in California, because that's where the implementation was going to occur, but also nationally we recruited people that had suffered from maternal sepsis, because it is a pretty rare condition. And the first thing what we did was we created a charter together. We sat down and got to know each other really well. We did a lot of status leveling procedures, and that no one calls me Dr. Bauer, it's Melissa. They have my cell phone, they have my email, we talk, we know a lot about each other, and we share all of our successes and our failures together, and we talk a lot about everything as far as maternal sepsis, but also, I received an email this week. Someone had just delivered a baby and they wanted to share their pictures, and we shared it with everybody, and there's a lot of respond to all, and it's all part of it. And so we created a charter that included standard operating procedures, decision-making policies, as well as a appeal process if there was a disagreement in some of the decisions that were made. And the purpose was to engage in research activities designed to understand and reduce maternal morbidity and mortality from maternal sepsis while leveraging community experiences and voices. Our members were maternal sepsis survivors, public health experts, health equity advocates, and community members from communities that have more barriers to care than in the suburbs, so in rural communities, urban communities, and tribal communities. We also had a clinical advisory board because we didn't want it to just be Elliott and I making all the medical decisions. We wanted to have nurses, midwives, and physicians all involved in this plan as well. So then now we had everyone together. We needed to work to reduce these 3 key deadly delays that we identified over a decade ago that was reaffirmed in California data that was reproduced to find that the 3 delays that lead to maternal sepsis deaths are delays in recognition, treatment, and escalation of care. And so the rest of this talk is going to focus on those delays and what we did to reduce them. And just if you're looking at your clock, 90+% of it is recognition, because if you don't have recognition, you don't have the other 2. I promise I'll finish on time, but let's go ahead and get started. So starting with recognition, we know that maternal sepsis is different, and we need different tools to help identify it, in that a lot of the physiological changes of pregnancy are very similar to signs of developing sepsis. So what happens with that is that patients are identified much later in the disease process, and time matters. So unfortunately, they're getting identified later, getting later treatment, and that leads to worse outcomes. So as far as screening systems, I don't have time to go through all of the incredible work that our team did, but we did publish several of the papers about it. But one of the biggest things that we try to do when we're doing statewide implementations is we try to say, try not to tell people exactly what to do. We give them the important principles and allow them to make decisions. And so we recommend that they use one of these screening systems. There's a ton of them out there, but we recommend that they use one. There's more and more data that show that it does reduce severe maternal morbidity. So we recommend that they use one, but also that they review their cases. And so if they're constantly missing cases because of the tool that they're choosing to use, then they need to be modifying that tool. We also recommend that they need different screening during pregnancy and immediately postpartum. This is also in line with CMS guidelines for Sept 1 that our team was able to meet with them and get them to change this. But that during pregnancy, so starting at about 20 weeks all the way through 3 days postpartum, we recommend a pregnancy-adjusted screening tool. And the reason for that is that their heart rate is much higher. It's about 25% during that time. And so it's really important to help identify those patients during that time. They're going to have an elevated heart rate without getting all of that alarm fatigue. And then prior to that, so during that less than 20 weeks phase and then after delivery, the heart rate actually jumps back down to normal pretty quickly within 24 to 72 hours. So we want to make sure that we're not still using that pregnancy adjusted criteria, because if you do from the time they're pregnant until 6 weeks postpartum, you're going to miss patients. And we showed that in our work. So it's really important to not use that criteria after that, because they may not have that elevated heart rate after they've gone home from the hospital, and they also may not have that elevated heart rate early in pregnancy. So you want to make sure that you're using a non-pregnancy adjusted tool during that time. This actually, I know it sounds confusing, but it's actually pretty convenient, because many times patients are seen in the ER at less than 20 weeks, and once they are discharged postpartum, they might go to the ER as well, and they'll be more comfortable using their non-pregnancy adjusted screening tool. So a couple of in-hospital recognition pearls that we taught not only to our community members for community dissemination, but also to our hospitals when we're doing our work, was that most patients don't have any risk factors. We found that quite a bit ago, that most patients just don't have risk factors. And so if you only focus on those at risk, you're going to miss the majority of patients. But also, no fever does not equal no sepsis. We've shown this multiple times in several different studies, including patients that have died 25% of them never developed a fever or hypothermia for that matter. So it could be from taking fever-reducing medications such as Tylenol or Motrin, but it also could be from immune modulation that also occurs. So we really work to educate within our communities too that you don't need a fever to actually have a serious infection and that you may not even have any risk factors. We also, looking at some of the papers that we had done before, we noted that most cases occur outside of the hospital. Remember, outside of the hospital is a really important time. So how can we help patients identify when to seek care? When we looked at the maternal deaths in the state of Michigan, many of them died at home, and we didn't know what happened. We didn't know if they reached out to seek care and they were dismissed, or if they just didn't know the warning signs to seek care. So those are both really important. So how can we help patients know when to seek care, and how can we help them feel heard when they do seek care? When we did our qualitative work of interviewing patients, we had common themes. So with theme saturation, we identified a number of themes that I'll go through and what we did to address them. But patients overall didn't remember education about warning signs. So we're either not doing it well, or we're not giving them the information in a way that's accessible. And so we have to address both. One of our exemplary quotes was, I think if when they discharged me, if they had said, be on the lookout for these warning signs, if you have any of them, call and check in, if they had taken 5 minutes to do that, I think it would have made a huge difference. And so what we found with our work, we interviewed every single patient that had maternal sepsis or had a family member that died of maternal sepsis, and all of them actually had one or more of these warning signs. These are from ACOG. These are copyrighted by them, and they are used in the AIM Cornerstone resource. And these are not just for sepsis. These are all severe maternal morbidity warning signs throughout pregnancy and postpartum. They're free to use. They're translated into over, I think, 90 languages now, and you can even request more. And this is a way to provide standardized patient education. We know standardization saves lives. There are actually quite a bit of data out there to show that patients do not receive the same discharge education from different nurses. And we want to make sure that bias is not seeping in there and that patients get all standardized education. And patients really do enjoy this. It's a really great resource for them. And it has infographics, so if you have challenges with literacy, that's also really important. But when we asked people, we asked too, how do you want to receive information? So it's not good enough for us to just give people information. We have to ask, how do you want to receive the information? And we talked to our community group as well as patients when we were interviewing them. And they overwhelmingly said they wanted it on their phone. And so the packets that we're very attached to that we like to give out many times don't make it out of the car, or they get coffee spilled on them and people just really aren't looking at them. So we have to also evolve with the changing, technology and give that to them on their phones as well. So we created this with the community leadership board. This is a badge buddy that goes on behind the nurse's badge. The patients will scan this at discharge and follow the instructions to have it as a bookmark on their phone. And so we sent this to every single nurse in the state of Michigan and more for when there's turnover, so that they could have this and other resources that I'm going to mention on their phone. We did have some implementation barriers with getting this going. I'm not gonna sugarcoat it. And so we decided we needed to pivot, which is really important in implementation science. And so we moved to cutting out the hospital part. We're talking about it's really important outside of the hospital. So April Chavez is one of our maternal sepsis survivors who works with us. She's also a graphic designer, lucky me, and she created this, and this is a business card. It's on the size of a business card, and we now give this out, and so people can have this. They have all the information they need, because community-based organizations as well as patients really responded well to getting this on their phone. They weren't getting it because there were some barriers in doing that. And so we wanted to just bypass that and have this so that people could just give it out. It's a one-stop piece of information, and it addressed some of the implementation barriers that we had. And so now we're distributing this throughout our community right now. And so I want to talk a little bit about community dissemination. Remember, it's so important to do this outside of your hospital. We had the support of so many people within the state to help get this information out, and they really responded well to it. We worked with our public health departments. We also worked with every single WIC site in the state of Michigan. We also worked with community-based organizations and houses of worship. People get a lot of their health information from their churches. And then also we worked with the doulas that were supported by Medicaid, as well as the home visiting nursing program. It's really important for us to understand that when patients have something wrong with them, they do not call their doctor and they do not call 911. They call their friends and their family. They call people that they trust. And it's based on what they think happens next. And so when a man has a heart attack, they actually call their spouse first. They call their partner. And based on what they say, they call 911, they go to the ER. And women actually do the same thing, but there's actually less concern when they start reaching out, because for some reason people still don't realize that women is one of the leading causes of death. They don't reach out. And when we were talking to our patients, we heard that people just didn't know that these things were concerning, that they were experiencing. And so if we don't educate everyone surrounding the patient, that they're not going to get the care they need. So we need this to be widespread, just like all the public health campaign for strokes and heart attack. Everyone knows when to seek care. We have to do that for pregnancy too. So everyone needs to know what these warning signs are. As far as advocacy, remember we talked about we don't know if people are feeling heard. We found that that was a major theme, and that patients really felt like they had to advocate for themselves to get the care that they needed. And one person said, I wish someone would have explained the signs and how to advocate for themselves. If you call and they tell you don't come, still go. And so we wanted to create a document to help people with that, not to say that it's on the onus is on the patient to have to advocate for themselves to get the care that they need. But while we're working on listening better, we need to provide people with that resource. So we created advocacy language and advocacy actions. We had a Zoom Jamboard session, and we had all of our community members as well as patients and our physician members work together to give words to say and what to do if you're not feeling heard. And we made sure that this was anonymous so that when I was putting this together, I didn't give more credence to something that a physician said compared to a community member. And we created this advocacy language and actions. That's a QR code that's live. You can take a look at it, go under patient resources, and you'll see all the resources we gave them. We use the same QR code because if you have multiple QR codes, someone's going to get the wrong one. So that's why we did it. I'm not going to go through all of this, but it really just gives people the words to say if they're not feeling heard, because they really didn't know what to say when they were in that circumstance, and also what to do as well. So bring a doula with you, bring a friend with you to help you advocate. A lot of really good information there. And so then this was a big one. Patient concerns were dismissed as normal or normal for pregnancy. CMQCC talks about this a lot. And one of the quotes that we had here, this was from a husband of his wife died during her hospitalization. He said, she's dismissed there and throughout the whole stay. Whenever we brought these things up, it was, you just had a baby. Everything's okay. Don't worry, you just had a baby. And that was the recurring theme throughout our stay. But they never asked further when she brought up those complaints. And so it's a really common complaint postpartum for someone to say, I feel really tired. But no one asked, when we interview these patients, what does that mean to you? What are you not able to do? And if they had asked, this is what they would have heard. I had no strength. I couldn't even go to the kitchen to get a glass of water. I was so weak I couldn't stand up. And I was short of breath after brushing my teeth and had to lie down on the bed. That's very different. These patients can't do activities of daily living because of their fatigue. And so we need to make sure that people are asking really important questions when people call. So we did the same process to create a warning signs follow-up guide. And this is just a really great way to ask good questions, to get a good history and also action items. So what, if the patient doesn't need to be seen now, what should you tell them about when to be seen? A lot of our patients didn't realize, they thought, well, I already talked to my doctor, everything's fine. They didn't know that if it persisted, if it got worse, if this changed, that they needed to seek care. So we provided that resource. Also some red flags, if these patients need to be seen definitely in person based on some literature as well as what we found with our qualitative work. Severe pain was actually a pretty common thing that we experienced with sepsis. I was pretty surprised by that. that, that was one of the first signs before they started having other symptoms as well. So now moving on to treatment, and antibiotics are really important. We know there's higher mortality if they don't get the antibiotics they need. We also listen to our hospital communities about how to get antibiotics quickly to people. So working to get it in the Pyxis was really important, having an order set, knowing which antibiotics to give, and then also having IV access. That's somewhere we can be really helpful, starting more IVs so they can start more than one antibiotic at a time. Otherwise, it's 2 hours for this, 2 hours for that one. It's 6-8 hours. They haven't received all their antibiotics. So we can step in and make sure to help with that. And then working with your pharmacies to get antibiotics quickly. And then fluid administration, it's 30 per kilo over 3 hours. I got a lot of hate mail over this because people were really upset about giving too much fluid. So I had to make a chart that I widely distributed of what ideal body weight actually is. And it's really sad, but if you're 5 feet tall, it's 100 pounds. So I had to make this chart, and 6 feet tall, even if you're a supermodel, you only get 2 liters. So this actually really helped everybody stop refusing to give fluids when patients had sepsis. And lastly, escalation of care. We recommended the sepsis and obstetric score. This is retrospectively created, prospectively validated to identify patients that need ICU admission with a score of greater than 6 or more. And I can't remember that chart, but if you go on your phone, you can go to perinatology.com, and there is a drop-down menu. You can enter what your patient has, get your score, get them admitted to the ICU. We put it on the Badge Buddy. Remember, we talked about we have provider resources as well, so that way everyone can find it at any moment. And we have a number of resources available if you're interested in implementing. And just a little plug, tomorrow the update of the sepsis toolkit by CMQCC drops tomorrow at 3 p.m. Eastern Standard Time, noon Pacific time, so please register for that. And thank you to the community board, clinical board, and all of our mentors, and I look forward to your questions. And my last question for you is think about how can we work with our communities and patients to improve maternal morbidity and mortality. Thank you.
Good morning, everybody. Megan, you're right, that never gets old, and I'm always going to stand here and wait for it. I'm not from the South, but I'm going to go for it. Thank you so much for the opportunity to be here today. Thank you to May and Megan and the APSF Planning Committee. This is a real privilege. Again, I'm Meg Rosenstein. I wear a bunch of different hats like many of us in this room. I am the Director of Obstetric Anesthesia and Associate Chief Medical Officer at Overlook Medical Center in Summit, New Jersey. I also have the privilege of being here with my partners from Napa, with whom I get to have some great quality endeavors. And I'm really excited to be here to share with you some components of our quality improvement journey in reducing maternal hemorrhage. I'm not gonna lie, I was nervous when May asked me to do this talk because the science that I'm talking about in this area, this isn't new. Now, that doesn't mean I'm not incredibly grateful to my peers, many of whom are in this room, who have worked tirelessly to define best practice. But what my talk really leans into is change management, how we align diverse practices, diverse providers to executing that evidence-based best care. Next slide, please. Okay, perfect. So before we dive into anything, I have no disclosures. This work is IRB waived under quality improvement. And to the right, you'll see a picture of Overlook Medical Center. That is my home for 16 years. She is very pretty at dusk, I have to say. Overlook is a community intensive perinatal center. We had roughly 2,200 deliveries last year. We are small. We are one of 7 Atlantic Health System hospitals, 5 of which have maternity centers. Combined together, those Atlantic Health hospitals deliver roughly 10% of the babies born to New Jersey's birthing patients. So collaboratively, we have an opportunity for significant impact, and due to some recent partnerships, I expect that that number and our reach in New Jersey is going to increase pretty monumentally. Okay, so moving on a little bit about New Jersey. Next slide, please. Okay, so New Jersey has a pretty difficult history of poor maternal outcomes. As recently as 2019, New Jersey ranked 47th in the nation for maternal deaths, and it has one of the widest racial disparities for both maternal and infant outcomes. In 2019, a Black woman in the state of New Jersey was 7 times more likely than her white peer to die from maternity-related complications. 7 times. So there's been tremendous work in this area. Thanks to programs like Nurture NJ, the expansion of Medicaid coverage to a full year postpartum, and legislative support for both maternal and infant health, New Jersey's making crucial strides. We are far from done, but we're headed in the right direction. One important component of the Nurture NJ program I've got demonstrated here, and it's transparency of and accountability for site-specific health outcomes data. So to that effect, the New Jersey Department of Health has released the Maternal Health Hospital Report Card. This update was released in February 2024, and it included data from 2018 up through 2022. We'll see a recurrent theme. Everything when it comes to state health data in New Jersey is slow. But what was really powerful about this tool is New Jersey's healthcare consumers now had a very simple way to log in and to compare site by site. What do patients delivering at each institution look like demographically? What are their complications? What are their comorbidities? They could make choices about where they're creating their medical home, where they're spending their healthcare dollars. This kind of transparency for a state with as deplorable a history as we have was not only radical, but incredibly necessary. And wow, did it draw the attention of hospital administrators. So what I'm going to point out before we move to the next slide here, on the bottom right-hand corner, you're going to notice two of our outcomes measures. We have maternal hemorrhage with that ugly red up arrow, and we have SMM with an arrow going down. Also throughout a form like this, our patients are able to see what resources are available to them. What hospitals are baby-friendly, have excellent lactation support? What hospitals have low rates of 3rd and 4th degree laceration? So a lot of information our patients are able to pull at their fingertips. Next slide, please. Okay, so while it was very distressing to hospital leadership and system leadership, Overlook's history of high hemorrhage rate among cesarean birthing patients was not news to us. I don't want to minimize the tremendous amount of work that's occurred in this space. We were doing the right things. We were utilizing pre-C-section huddles. We were measuring quantitative blood loss, using hemorrhage bundles based on ACOG's Safe Motherhood Initiative, updating them with AIM. We had high-fidelity simulation that was mandatory for all team members on L&D. We made it mandatory for anyone taking anesthesia call on the labor floor. And yet, despite all of this work, we weren't moving the metric. Every case of hemorrhage was reviewed at Overlook for trends, for anything that we could find systematically that had not supported that patient's care. Each of those hemorrhage reviews was reported out to perinatal quality and safety at a local level, and then higher up at a collaborative level all across Atlantic. And as you'll see, we went through, if we can click please, we went through and validated the state data. There should be a bar that pops up on the bottom, if our tech team can just advance or click. There we go, and one more time for me, please. Thank you so much. So we can see we validated our data from 2021 and 2022 with Atlantic internal data. And the state was right. And unfortunately, despite all of this effort, despite all of this energy trying to align our teams to best practice, defined by you, we really weren't moving the mark. So we're going to go to the next slide, please. Thank you. So with the release of these reports and a lot of anxiety coming at a system and a local leadership level, I found myself following one of my mentors' most valuable pieces of career advice, and that's raise your hand for the messy project. Raise your hand, step in, and start to build your team. So we pulled together a really robust multidisciplinary team. Previously, hemorrhage at Overlook had really been maintained insularly in the obstetric community. We wanted to branch out beyond that. We partnered with maternal fetal medicine, with hematology, with nurse leadership, with local nurse managers in our practices, with our Health Start clinic that serves our and underinsured patients. So we created this very robust, respectful, diverse team to try to break down what the root causes of hemorrhage at Overlook were and try to identify tests for change. Those of you in the room who are lean trained, you know that's some of the language that I'm leaning into. Lean methodology and anesthesia go hand in hand, so that's an easy place for me to start off with these projects. So you'll see that we created tests of change or interventions across the full continuum of maternal care, and there's two that I'm going to highlight for you today. Those are antepartum anemia optimization and the early recognition and management of obstetric hemorrhage. So we'll start with anemia. Next slide, please. Thank you. So why anemia? Well, anemia is one of the most common health problems that pregnant women face, and there is a strong correlation between antepartum anemia and the severity of intra and postpartum bleeding. CMQCC's Hemorrhage Toolkit identifies antepartum anemia as an important and potentially modifiable contributor to SMM. The most common cause, as we all know, of anemia in pregnancy worldwide is iron deficiency anemia. And as we discussed yesterday, iron deficiency anemia is a health equity issue. It aligns closely with social determinants of health. There are higher incidents of iron deficiency anemia among Black and Hispanic birthing communities. CMQCC and ACOG align very closely in their recommendations for early identification of iron deficiency anemia, iron store repletion, and the ultimate goal of achieving a hemoglobin of greater than 11 grams per deciliter by the time of delivery. New Jersey actually did us a favor as well. The New Jersey Department of Health report card included methodology, and in that methodology was logistical regression analysis identifying independent risk factors for obstetric hemorrhage. The odds ratio for anemia was 1.29. And while comparisons are a little challenging in this setting, that odds ratio, interestingly, exceeded that for preeclampsia, for obesity, and for Black race. The report card also demonstrated that our rates of anemia at Overlook Medical Center were significantly above the state average. So we had our first target for intervention. Based on recommendations from CMQCC and from ACOG, we knew what best practice looked like on paper. The algorithm is relatively simple, it's relatively prescriptive. We check a CBC and ferritin in the first trimester, again at 24 to 28 weeks, again at 32 to 34 or even 36 weeks. And there's fairly clearly prescribed actions based on laboratory results. This model had been utilized at our Health Start clinic, which had demonstrated pretty significant success, improving our outcomes for our most vulnerable patient population at Overlook. The challenge here, however, was not knowing what to do, but how we could achieve buy-in and standardization across a diverse obstetric set of practices that comprised Overlook and ultimately Atlantic Health System. These ranged from large multidisciplinary groups that were not owned by Atlantic, Atlantic-owned practices, midwifery groups, and a few solo practitioners who still remained within our catchment. We could literally spend hours or an entire conference talking about the process of change management, and I think a lot of us have touched on that during our comments here. But the bottom line is this: we needed to create a burning platform. As a team, we needed to provide and agree upon consistent language for why there was a necessary need for change and what the danger of the status quo was. This was particularly important for us because overwhelmingly at Overlook, our moms went home seemingly healthy. 40% of our hemorrhages were low volume, less than 1,200 mLs. Our transfusions were infrequent, admissions to the ICU were quite infrequent, and our rates of SMM were well below those of the state average. We needed to have a compelling reason to get our obstetricians and our midwives, all of our collaborative care team to participate. So once we had achieved buy-in, then the team turned to tackling logistics. We went, and again, this is a small-scale project, we went to every single practice. We met with the practice managers, the nurse managers, who are the ones who are executing the mechanics of care, and we learned so much from them about barriers. There were barriers to accessing appropriate hematologic consultation. So the team went back. We partnered with Atlantic Health's hematology groups, and we worked on a pathway to execute and prioritize consultation for our antepartum patients. We also developed and provided to interested providers, both midwives and our obstetricians, access to care plans within Epic. It was a 1-hour training that they could take, and following the Atlantic algorithm, they would then be able to send their patients to infusion centers within Atlantic to receive intravenous iron, bypassing the need for hematology for our simple iron deficiency anemia cases. It took time, but as you can see in the graph on our right, our anemia rates are getting better. And I'm very proud of this group. They are actually the best in the system, and we've taken our roadshow throughout Atlantic's 5 delivering hospitals, and we're seeing systematic improvement that's benefiting our moms. So I'd also like to briefly touch on strategies employed for the early recognition and management of obstetric hemorrhage. As I mentioned before, we had some good structure in this area. We were doing QBL, we were utilizing the hemorrhage bundles, we had simulation. Thinking back to Elliott's talk yesterday, we had the toolkit, but the teamwork and the timeliness, they were a little bit lacking. Incidentally, when the release of the report came out, we also noticed an uptick in our hemorrhages for vaginal deliveries. So that kind of gave us the idea that we needed this robust response at stage 1, both for vaginal and cesarean. So if we go to the next slide, that's exactly what we set up to do. We took this opportunity to reassess our response to stage 1 hemorrhage. And again, these are not novel strategies, but when used consistently through a shared mental model, they are highly effective. In particular, the implementation of a huddle at 500 mLs QBL addressed those Ds that we heard about yesterday: denial, delay, and dismissal. These huddles can be triggered by any member of the team. And thinking back to May's discussion yesterday, by having any member of the team feel empowered to speak up and say, hey, I think we're approaching 500 mLs, let's call together a huddle. We improved team members' willingness to speak up, and we reduced that kind of psychological barrier by creating safety for them in that space. We also increased our resources by having additional RN and OB resources come to the bedside as this huddle was occurring. That reduced barriers to achieving extra assistance in the room because it removed the stigma for asking for help. Help was already there. So let's see, how are we doing now? We're going to go to the next slide. Okay, so anytime we're talking about state data, again, it's very slow. I have 2023, which is expectedly bad. We knew that that was coming. You'll see the long lines that are going to go all the way to 2025 year to date are Atlantic's internal data, and then we can see the state averages, which are below where we are. Atlantic had a significant gap in cesarean rates of hemorrhage, both in 2021, 2022, and 2023. But we're moving the mark in a really important way. We've reduced our rates of hemorrhage significantly for both cesarean and for vaginal deliveries, and we're moving in the right direction. We're also seeing this work moving more broadly across Atlantic Health System through the OB Collaborative and the postpartum hemorrhage work group, which many of our team members have stepped up to take leadership roles in. So it's been a great opportunity for us to learn within our local institution and spread those good learnings across the system. So I hope what you'll take away from my discussion today, and I did keep it brief, was not so much the road to reducing hemorrhage, though I am in for that work. I'm here to celebrate you. I appreciate the work that you do, and I'd love to partner with you in that endeavor. But rather, what I want you to consider is the role that our anesthesia community can play in teaming, in change management, and in process improvement. Whether you are an innovative researcher, a community provider like me, whether you're training the next generation of anesthesia providers, each of us is going to be integral to this journey of improving maternal outcomes. I'm really looking forward to our discussion later today, and I just want to leave you with, think about that project that you want to undertake, think about the team that you need to do it, and think about that burning platform, that compelling argument that you're going to disseminate to get those first followers. Thank you so much.
Hi everyone, my name is Yasuko Nagasaka from Tokyo Women's Medical University, and it is my great honor to be here. Thank you, May and Meghan. It's such a wonderful group of people, the APSF family, and I'm part of it. So I'm gonna start. This is my COI, and I am gonna present two different research topics, and part one will be the maternal mental health, and the part two will be the pediatric neuroprotection. It's kind of different, but it's like a two sides of coins. Moms and babies always matter together. So as a background, I would like to mention these two articles indicating reduction of the risks for postpartum depression by giving labor epidurals. And the upper paper from 2014, the Dink et al. Reported that women who received the epidural labor analgesia had significantly lower incidence of postpartum depression, 14%, whereas compared to the ones who did not, 34.6%. So that's a big paper that everyone cited. But after that, the meta-analysis came out, and this shows that the results from this meta-analysis that conflicts what were previously published. And the study concluded that the labor epidurals were not shown to protect against the development of postpartum depression. But we should be cautious about the data because as current modern medicine does not allow pure non-analgesic labor. So unless the countries like Japan, where OB anesthesia is still not a standard care for the patrients for the vaginal delivery, so these might not be a good control group to draw out the conclusion. So what is unique about Japan? Because I practice in both countries and I'm board certified in both countries, so I can see through my different sets of eyes. And I would like to mention how we're doing in Japan. So this figure shows that the provision of labor epidurals in our patient population is pretty low. So although there's a great gradual upwards trend, the reported rate in 2023 was just 11.6% across the country. So almost half are done in small clinics with a single provider model by obstetricians, which is another different big topic, which I will not go into for today, but they provide labor analgesia by themselves. And this indicates that there are not enough anesthesia providers available in our country. So on the other hand, you can see what we do have for the pure control group who does not receive analgesia during labor and delivery, besides the local anesthesia infiltration. So it occurred to me when I went back to Japan in 2016 that we should study our patients. So what is also unique about Japan is that, as shown in this figure, suicide has surpassed all other causes of death, such as hemorrhage, AFV, or intracranial hemorrhage, becoming one of the leading causes of maternal mortality. In 2022, it was as much as 23%. And the literature suggests suicide rate increases with maternal ages in Japan. So furthermore, many of the suicides occur during the postpartum period, which highlights the issue of postpartum depression. So this study that we did is to investigate whether women who received labor epidurals have lower risks for postpartum depression than women without labor epidurals and cesarean section in Japan. So we have presented this data at the ASA last year. And this is a single-center perspective observational cohort study, and we include women above 18-year-old with uncomplicated singleton pregnancies. We used surveys with a questionnaire which they completed at the start. That was around 35 weeks of gestation. The EPDS score, that was for the postpartum, but they can use for the prepartum as well. And we followed up the patient at 3, 6, and 12 months postpartum. And this included their scores on the EPDS, and we also gathered information about the maternal, infant, and anesthesia from their birth record and electronic chart. And the primary outcome was the EPDS score at 1 month. And these are the patient characteristics for the 3 delivery modes: vaginal without labor epidurals, cesarean, and vaginal with labor epidurals. And there were significant differences in age, baby weight, and satisfaction with pain management during delivery between the 3 delivery modes. As you can imagine, vaginal delivery without labor epidurals had the worst satisfaction on the pain control here. And these are overall results of the EPDS score. Women with positive EPDS scores of 9 or above was 9.4%. And then at 35 weeks, so pre-partum, and then 10% at 1 month, so almost no difference, and then 5 to 6% thereafter. And significant differences were noted only in antenatal EPDS positive rate and the antenatal EPDS score. And multiple regression analysis with the EPDS score at 1 month postpartum was at the dependent variable was used to evaluate the impact of multiple factors on postpartum depression and BMI, and administration of the labor epidurals and antenatal EPDS scores were significantly associated with higher EPDS scores at 1 month. Bless you. In the Japanese population, these results suggest women who received labor epidural may have higher risks of depression at 1 month postpartum. And higher antenatal EPDS scores were predictive of higher postpartum depression risks at 1 month. And we have almost finished the study and now in preparation for submission. So I would like to thank Dr. Fujita for doing all the work. And the second half is about the pediatric safety in anesthesia. So this is a statement about the use of anesthesia medications in pediatric populations, and the SMART statement came in out in 2015. So in 2016, the FDA published new warnings about the usage of anesthetics and sedation drugs in young children and pregnant women. And they revised the safety communication included, they suggest postponing scheduled surgeries to be performed after reaching 3-year-old. So the researchers in Boston and across the world did the first prospective clinical randomized control trial to explore the effects of anesthetics on the developing brain in humans. And this is an international, multi-center, randomized control trial, including 28 hospitals in these countries, including the one in the US, Europe, Australia, and such. And so for the control group, they got the regional anesthesia plus sevoflurane, maximum of 8.0%, which is pretty high. And the intervention group got the regional plus awake. And they evaluated the neurodevelopmental outcomes at 2 years of age, which was a secondary outcome, and 5 years of age, which was a primary outcome. And after 2 years, the Bailey scales and MacArthur-Bates score revealed that they were not significant. And at 5 years, they used the WIPC 3 scale IQ score, and again, the results were not significant. So the lessons from the GAS study is that slightly less than 1 hour GA in early infancy did not cause the neurodevelopmental problems at 2 or 5 years, and which means that we did not change anything that we were doing, and we could keep on giving the anesthetics as necessary to our patients. However, when I went back to Japan in 2016, there were so many little children crying in the PACU, like having emergency agitation or delirium. And back then, the SMART statement was not fully disseminated in the country of Japan. So pretty small children getting surgery, like mole removal or such, And I thought that might be the reason that the kids are having delirium after surgery. So here are my questions. Why are small children develop emergent delirium agitation after the general anesthesia? And when you go back to this article from 1953, which was published in a journal and later became JAMA Pediatrics, and they used a questionnaire mailed at 2 months after the operation, and they checked the personality change, including nightmares, temper tantrums, bedwetting, afraid of strangers or new odors. And here are the results. A single-center prospective observational study over 18 months period, and the kids had ether for the anesthesia, and after the otolaryngological operation. And they found that the x-axis is the age, towards the left is the younger, and the y-axis is the percent change in the personality. And they found that the incidence of personality change was highest in the youngest children. And also, the literature suggests the prevalence of emergent delirium is about 18 to 30% in children. And here are some important features emergent delirium summarizes in slide in this review article. So probably in preschool children, 1 to 6 year old with anxiety, presents with high intensity of anxiety after sevoflurane or desflurane anesthesia. It included pain or no painful procedures, and prevention included as such. So it occurred to me that the depth of anesthesia might be too deep in our patient populations. And we can monitor the depth of the anesthesia by using EEG, right? So we decided to use the EEG to titrate the depth of anesthesia, sevoflurane anesthesia, in our patient populations. The EEG signal is composed of different frequency waves, and the machine separates that. And when you get the raw EEG, and the machine separates that, and they color code by the organization of frequency magnitude. When you have much waveform, the higher power, then it gives you the warm color. If you have less, then it gives you the cold color. And then when you add up according to the time, then you get this nice screen to help you analyze the waveforms by color coding. And when you give propofol to adult population, like infusion of the propofol, and this is the time for the x-axis, and then LOC means loss of consciousness, and ROC is the return of consciousness. And when you are under propofol anesthesia, you get the alpha wave and delta wave, to be simple. And of note, EEG during anesthesia are different between the ages of patients. And this is an article studying sevoflurane anesthesia using the EEG. And alpha wave is only observed after 6 months of age. And that's why we decided to study the age between 1 through 6 year old. So using this EEG tool, I will give you some literatures from the pediatric population, then move on to the studies that we did. And since we're going to review some papers, I'm going to highlight we're using this fish going upwards as a positive study, and then negative study is horizontal, okay? So let's move on. This is an RCT published in 2022. They studied 220 patients rather getting EEG-guided anesthesia or standard anesthesia care, and the result has been shown as here. So they used the indexed number rather than reading the raw EEG or the DSA, the color coding waveforms. So there was no statistically significant risk difference between the PAED scores between the two groups. So it was a negative study. And here's another article, an RCT studying 40 pediatric patients undergoing ophthalmology surgery, and they are the high candidate for the PAED. and EEG-guided BIS management. So again, they use the indexes number for the high normal BIS of 55 to 60 or versus low normal 40 to 45, which is the deep anesthesia. So they compared the light anesthesia versus deep anesthesia and see what happened. So here are the results. So end-tidal sevoflurane concentration titrated to BIS did not reduce PAED mean score. So it was again the negative study using the index number. So we have learned that the emergence delirium may correlate with epileptic EEG in children with deep general anesthesia in other articles. And EEG-based approach may reduce requirements for sevoflurane anesthesia. And EEG-based intervention by PSI or BIS indexes, the numbers in children did not reduce PAED. So we did an RCT. So we performed a RCT to investigate the effects of reduced anesthetic exposure on PAED, and we recruited 200 children aged 1 through 6 without neurological issues at baseline, who are scheduled to undergo general anesthesia for more than 30 minutes for the procedures allowing reliable anesthesia such as local or regional blocks, plus remifentanil infusion. And our patients were randomized to intervention or control group. The control group received standard sevoflurane anesthesia with fixed level of sevoflurane, induction of 5% and maintenance of 2.5%. And then the intervention group received sevoflurane anesthesia titration by the EEG, whereas the control group received such. And the primary outcome was the proportion of patients with a PAED score of 10 or greater. And the secondary outcomes included the actual PAED score, as well as the sevoflurane exposure, time to emergence, and length of PACU stay. And in order to test our hypothesis, I asked Dr. Emery Brown to accept my fellow Kyo Miyasaka. Dr. Miyasaka, who is very well known to the APSF world, he was his son. And Kyo became Dr. Brown's research fellow for 2 whole months, and Dr. Brown kindly taught him how to read the pediatric EEG. And then he came back to our hospital, but we did not have enough pediatric patients. So he went to study with Dr. Suzuki, who was the chair back then in the National Children's Hospital, the biggest children's hospital in the whole country of Japan. And he did the study. So we recruited 218 patients, and the final number of the patients were 91 in the EEG-guided group and 86 in the standard practice group. And here are the example of DSA in pediatric patient undergoing sevoflurane anesthesia from the left to right. So awake state, induction is pretty deep, and maintenance, we maintain the patient under anesthesia by EEG guidance with the delta wave and alpha wave. And if it gets too lighter, then you increase the sevoflurane dosage. If it gets too deep, then you will decrease the sevoflurane dosage. And here are the results. So the incidence of PAED was lower in the EEG-guided group compared to the control, and the overall incidence of PAED was about 30%, which was consistent with the previous reports. And the table on the left shows the number of patients in each group above and below a PAED score cutoff of 10, and the box plot on the right shows the maximum PAED score for each group. And on average, the patients in the EEG group were exposed to less than half of amount of sevoflurane. I'm going to skip these slides because the time is coming. And what we found is that with EEG, patients emerged about 25 minutes faster, and they discharged about 20 minutes earlier from the PACU. So in conclusion, we were able to reduce PAED by controlling exposure to sevoflurane by EEG-guided titration without compromising surgical anesthesia. EEG-guided titration of anesthesia also led to faster immersions and shorter PACU stays. And it may be possible to greatly reduce sevoflurane use in pediatric anesthesia with EEG guidance and multimodal anesthesia techniques. But the most importantly, it's not just a matter to placing the sticker over the forehead, but the largest next step is to learn how to read it. So I would like to thank everyone for listening to me, and I will take any questions if you might have. So thank you so much.
So that concludes all the prepared talks, and we now move into the action phase. So if you look at your program, you'll see that we have not programmed a break. We want to keep you in the room, but we do invite you to stand up and stretch, grab some coffee. My colleague here, Della, Lynn, is going to explain exactly what we're going to do with our breakout groups and how we translate all of the amazing information that we've shared and learned over the last day and a half into action. So Della?
Yeah, all right. So I'm not doing a presentation. This is your time to be creative, unleash your energy. So please stand up. I won't be offended. Stand up, go get some coffee. Preferably don't go to the bathroom so you'll miss the directions, but wiggle around your arm and your leg and kind of get everything going so you can be really creative. So how many of you have ever set an alarm clock and pressed the snooze button? Yeah? So like our brain told us we need to set our alarm clock, and there was something in our gut when that alarm clock went off where we're like, no, I'm not going to do that. And so we want to talk about what we can take going forward, and to use Elliott's metaphor, the last mile. Well, it might be the penultimate last mile, but towards the last mile, with all of the information that you've heard over the last day and a half, a tremendous amount of information. And so I'm going to just use the metaphor of the elephant and the rider, which some of you know, and I'll just explain it briefly for those of you not familiar or need a little refresher. So this was popularized by a psychologist, Jonathan Haidt, and then even further popularized by Dan and Chip Heath with the book Switch. Basically what it says is that for us to change, there are sort of two sides of us in human behavior. There is the rider, who is the very analytical, rational person who's probably thinking about some of the great things we've heard today, right? Let's have a checklist. Let's have some scores. I see Carol here. Let's have a care plan for the patient, right? That makes total rational sense, that the patient should have a care plan in their hand as they're going through this. I think Dr. Olympio had another good one yesterday about, like, why don't we have a leader? Like, who's in charge of this, right? Those are great rational decisions. But then we've got this massive elephant, the really powerful elephant that is driven by emotion. Emotions are great with stories, get moved by stories, hitting the snooze button, but also habits, right? The elephant is really hard to change course. If we're in one position, it's really hard to move the elephant. So the idea with the change management theory is that we need the elephant and the rider to work together. So what we're going to ask you to do is to get into breakout groups. We're not going to actually assign topics. We've had to cut out some of the Q&A. So we want you to take the first 15 minutes or so in your group to just talk about what were some of the great takeaways that you're going to take back to your organization. We'll have Post-its at the tables so you can write them down first and then talk them out loud. And then after about maybe 15 minutes, decide on one. Now you'll have dots at your table, so if you want to use the dots to be able to vote and give yourselves each 3 dots and vote on which one thing you're going to be, a takeaway you're going to really drive to that last mile, or you can do raise of hands. It's not prescriptive, you just pick how you want to get to the one thing. And then the last half hour is to figure out 3 things when you come back to report out. One is, how are you going to inform that rider? How are you going to direct that rider? Now remember, that rider thinks that once they have that direction, they're going to guide the way. But we know that the elephant has a huge power to move things the other way. So what are you going to do, number 2, to motivate the elephant? What are we going to do to motivate the elephant? The third piece is the path. So you could have a great driver, you could have the elephant with the driver, and then the path is littered with stuff that's in the way. So how do we make sure the path is clear? I think we heard some great ideas. What happened to Dr. Men? I forgot how to pronounce her name. Thenwara and her Iowa project, right? She cleared a path, right? So the third thing is, what is the path? And I'd like for us to think about, what does that path sound like from a patient standpoint? So if the patient were to pitch this whole thing, the rider, the elephant, and the path, what would that sound like? When you come back, ideally, you would have 3 people to present, so not one person with a bullet point. You could do it that way if that's the way you want to do it. But I'm going to suggest creativity and maybe have 3 people. You can do it as a skit. You will have flip charts, so if you want to draw it as a picture and show us as a picture. I've had some people who are so creative, they even have a PowerPoint ready in that short amount of time. Go for it if you want to do that. But just be creative and come back and share with us, how are we going to get to that last mile? What are we going to do for the rider to inform that rider? What are we going to do to move that elephant? And what are we going to do to clear the path? Any questions? Perfect. How are we, Meghan and May, how are we going to divide people up? So we do have some breakout rooms downstairs, but we think because of all the movement going downstairs and upstairs that we actually can keep the breakouts right here. So I think we can do them in the 4 corners of the room. Go ahead.
So we're going to do breakouts in the 4 corners of the room. So if you imagine that this is one line and then there's another line bisecting the room, we want you just to disperse to the corners. So you're already in those quadrants, so just move to the corner, and you'll each have a facilitator that will walk you through exactly what Della said. If you feel like one corner's a little bit overweighted, feel free, like this one's a little light, but we just want you to disperse farther away from the middle into the corners, and then we will guide you through this exercise.
We'll probably give you a ding at about 15 minutes, so you know that at that point you should be starting to think about, if you haven't already, what the one thing is. And then we'll give you another ding at maybe half an hour. So if you haven't started at that point describing what kinds of change things you're thinking of, you should be doing it. So we'll give you a ding at 15 minutes and at 30 minutes. So we're at the 15-minute mark, so just if you haven't started to think about prioritizing, in the next 5 minutes you should think about prioritizing. Okay, this is now your second notice. It's at about the half-hour mark. So if you haven't picked a spot and started to think about your 3 things and unleash your creativity on how you're going to present it back to us, this is the time you should be moving into that. Right. The 1 minute mark. Time to report out. We draw straws to find out who goes first. Okay. By the way, did anybody find a black case that's got sunglasses and eyeglasses in it? I seem to have put my thing somewhere. Oh, these guys want to go. All right, these guys, they're jazzed now. I know, I got them jazzed. Okay. Do you want to do it up on the stage, or you want to do it from here? Okay. You can do it from here as opposed to up on stage. Do you need to do it up on stage for the live stream? I need to ask them. Do you guys need to? Do we need to? Mike, do we need to do it on stage for the camera?
Yes, we can. What do
No.
you want on the screen?
No. They're going to be presenting. Do we need? Is it okay for them to just do it from here?
Oh, I see. They won't be visible on the stream if they do it from the tables.
Okay with like going up on stage? Okay. All right. I thought you guys were going to do a joint thing.
It's a disjointed thing. I'm not, but since it's a disjointed.
Okay. All right. Okay. There we go. All right. So we have our first presenter. Sorry, we decided that because it's got the camera thing, we need to do it up here. Otherwise, they won't see. I'll give you the microphone here.
Actually, we do not have a team name. Oh yeah, there we go. So, well, I'm really excited to have the opportunity to go first here. I want to say we had a group of very diverse perspectives and quite animated discussions. But ultimately, we settled on checklists and the implementation of checklists at our institution as the most important thing. And in terms of directing the writer, it was really interesting to us to know that the abundance of guidance that is out there, but it's still a little unclear how accessible that is. So that will be something for us as individual project leaders and drivers to really figure out what to pick, what to use, and where to get information from. And then, of course, how do we motivate our systems, our providers, and how do we actually do all that change and implementation of practice change. And for that, we really thought about how important it is to have the input of stakeholders, maybe through surveys or similar modalities, to really figure out what are the barriers, why do people have resistance to adopt checklists, what are the practical barriers like time, what are maybe our own anxieties and insecurities, and how would it all be perceived by all the different stakeholders, including patients. So those were kind of the first two, and then for the patient perspective, I have an actual patient advocate here.
Thank you so much. I think checklist utilization is something that was perceived as maybe a provider wouldn't know exactly what they were doing given any OB emergency or even non-emergency setting. One of the feedback that we got about checklists was people didn't want to utilize an AFE checklist for fear that it would incite fear of a patient asking, wait, what is that? Or concern that they didn't believe that their provider knew what they were doing. And so from the patient's pitch, I would say if I were receiving care and someone said to me, oh, let me go grab this checklist really quick, my first thought would be like, this is fantastic. They obviously know what they're doing. And then for the provider to say something like, I'm just going to use this checklist or in order to make sure that I don't miss anything, it creates confidence for us to know that you have a lot to remember. And I think all of us use checklists, whether it's a sticky note or our phones or reminders, that things get missed. We have a lot of things going on. So I think that resonates with patients is it's totally okay to use checklists. And so long as it's being vocalized that, hey, I'm just gonna make sure you're gonna hear us listing some of these things. So that would be my patient's perspective of the utilization of checklists.
Great. Okay. Normalization of checklists. Where's Alex? You must have really liked that one, huh? And you weren't even in that group to have infused that over there. All right. Who wants to go next? You guys.
Okay. There's going to be three of us presenting. Brent Lee with Napa. So our group talked about, we really felt like one of the most overarching strategies that we could do would be to really take a seat at the table. And I think we were very convinced by Brian's talk this morning that everything else really follows if we can get involved. And I think that's really the key. In terms of direct the rider, there are many riders, and I think all of us, whatever position, wherever we work, whether it's a community hospital, an academic center, we have the ability to get more involved, to be more engaged, and to actually really demand a seat at the table. I think our expertise as anesthesia providers really, I think, is valuable in the whole perioperative or peri-delivery setting. And I think that the first step is to really educate yourself, look where you can get involved at whatever location, situation you're in, and I think that's our first step in Direct the Rider.
And then after you have decided which location you are, C-suite, big OB, academic center, small place, only you and the rest of you, pick up an issue. Whatever the OB issue is it going to be access to care? Is it going to be hemorrhagic? Is it going to be, prenatal anemia? Many of the great things that we have discussed during this meeting, and motivate by creating a sense of urgency. And sometimes the urgency is by just sharing stories. The stories that were shared yesterday were amazing. I don't think anyone is going to ever forget the pain, the visceral pain, and that's going to be burned in our brains. Well, the same thing is going to be happening to the C-suite when they see the stories of the two hemorrhagic patients that either died or had a bad outcome, or to your anesthesia colleagues when you explain how visceral pain is a real thing and these are the statistics. So it can be just emotional by engaging them. It could be with certain data when you have to explain to the C-suite that you are going to improve the rating of patient satisfaction by just creating this team. And that motivation is what's going to be targeting the right person. Use the right tool to motivate the right person during this process.
Thank you. All right, and then for pitching the path from the patient's perspective, really keeping the rhetoric the same. If we want a seat at the table in these discussions, we also want our patients there too, and we want them to know that they are at the center of our decision making. They're in the driver's seat of their own care, and that we're here to listen to them as well. So making sure that they understand that we want them to feel safe, that we want them to be at the table, be a part of the discussion, be a part of your care team's decision making, and then also saying that you deserve a team who puts you at the center of it. So, thank you.
Great. No, wonderful. So, what did I hear? I heard a seat at the table. I think that was the main common theme, right? Seat at the table. Create that urgency with stories. So I guess we're whispering stories to the elephant to get him to go. And I don't actually know if it's a him or her elephant. And actually the seat at the table, even the patient has a seat at the table. So instead of doing things for the patient, we're actually doing them with the patient. So wonderful. All right. Oh. Go for it, Lynn.
Yeah, we didn't have many join from online, so my mind goes back to enhanced recovery after surgery, right? Where we're really focused on that patient being optimized for the experience, and it's not just when we see them for delivery. It really is that prenatal, the perinatal, and the postpartum. It's the whole picture for that patient. And it really resonated with me when our one presenter, Carol, talked about the nurse midwives in the UK, because my daughter had a less than favorable experience with her first delivery. And this time I actually got to be there, and the nurse midwives, the whole team planned with her, psych mental health, pain management, everything, so that she could have a favorable C-section this time. And then just the nurse that would come to check, then the nurse midwife, there were people coming every day checking on her and the baby. And what can we do? So for me, the kind of the elephant issue is we have very disparate ways that we manage our patients. The obstetrician may send them in to see anesthesia if they think there's going to be an issue with an epidural or whatever, but or they had a really poor experience, but we're not connected across that chasm, and the patient isn't prepared to drive their own care. The checklist is a wonderful idea, but how do we let the patient be the rider, really drive what's going on in their own experience and care? So that's a huge question, and I think healthcare reimbursement gets in the way, for sure. We don't have the nurse midwives in this country. We don't have medical assistants that are working with the patients that would be driving like a concierge service across their care that wouldn't be expensive. There's many models that we have in other types of care that we could use. So rider, elephant, and the path to smooth it out is that team communication, that connection, touch points that people and the patient could check in on the plan of care. Okay? All right.
And it sounded like lots of touch points, right? Like you said your daughter, which by the way, I guess you figured that out. Her daughter had a baby in the UK. had visits all the time to her house, so she didn't actually have to go. Yeah. And then pointing out the old habits that our elephants have of individualized care, individual ways that we take care, not that the patient's care shouldn't be personalized, but that we all have our individual habits that maybe we need to break. And I think that's what I wrote down. Okay, this group. Are you guys okay going last? Okay, you're the anchor, right? Okay, all right, over here. Oh, I love it. I love a team presentation. Much better than...
It's all about team. We had a wonderful group, really representative of, I think, what the APSF stands for, and that's multi-professional, multidisciplinary approach to safety. So we actually have a patient advocate who voiced a lot of great ideas, and we'll talk about that. But our group really focused, again, on the checklist. We had a little bit more granularity with regards to what that might look like. We actually wanted to take more of a cockpit approach so that we would break it down into obstetrics, anesthesia, nursing, and patient/partner. That patient partner, we'll talk a little bit out in a little bit, but we would have each group provide their concerns, their perceptions of what needs to be done to give the safest, optimal care to the patient, and we would do that in sort of a huddle approach every shift, 24/7. That would be at an area that the 3 groups or 4 groups could convene. The patient partner part of it would be funneled through a whiteboard in the room. That information would then get translated into the checklist that we would discuss at that time with the 3 healthcare professional groups. So what the group thought is that the APSF should lead the way in helping develop a task force to create a standardized cockpit approach checklist that would help folks really be engaged. So we could also use the checklist to enhance team building and collaboration in that huddle 24/7, which I think, a lot of us may do this during the day, but it kind of falls off at night. So I'm going to talk about the patient perspective.
Thank you. So yes, from a patient perspective, I think what we might see, we've talked a lot about the patient perspective is going to have a lot of variety to it. And so when you go into that birthing room, you hopefully this checklist includes a way of identifying what the state of that parent and that family is. So for example, they may have a very strong plan and a lot of opinions about whether they're even going to have an epidural or not. Or it may be more of an emergent situation where they don't have a lot of education. They don't have a lot of preconceived ideas. Maybe they don't know about safety. Maybe they know a lot about the need for safety. So depending on wherever that is, that really becomes kind of the elephant, if you will, that motivates that checklist forward. And then from there, that whiteboard becomes the central symbol and key where we connect very quickly. And it's a mirror back. It is, for example, a cue for those providers who are coming into the room to say, you have a preference, we acknowledge that preference, and we want you to also know that we're prepared for anything that might be unexpected or not part of your plan. And that gives some confidence that there is a team approach, that even if I have only worked with one person up to that point in my birthing plan, or I've not worked with anyone, I'm covered by a number of different possibilities. And we even talked about the possibility of that checklist including some tools. For example, a short video that has removed the bias around whether I should or shouldn't, but it's just plain information that helps me very quickly arrive at a decision if I have not already made one. So I think that covers it. If I missed anything, let me know.
Yep. Thank you. Any questions?
Alex, you didn't have anything to do with checklists being part of this. Huh? But I heard multiple checklists, but really to make them cohesive, to make the team cohesive, right? That was the point.
This is I spoke yesterday about a crisis checklist. This is more
routine checklists. Routine checklists. So that there was a plan, and that the plan may even include some what-ifs, so that the patient feel comfortable with a what-if. Structured discussion that's on a routine basis, and creating confidence, a sense of team, and trust. That's what I heard. Okay. All right. And our anchor. Who's our anchor?
Okay, so we had a lively discussion and focused on patient education. We thought the lowest hanging fruit would be better patient education. We think a lot of that is out there, whether it be SOAP or different societies. So we think, one, partnering with those societies can be very helpful. And then our problem with the elephant, I guess, is how do we get the patient to the education? How do we actually get access to it? So we talked a lot about social media. We talked about other forms of getting the word out, partnering with clinicians. I will let you.
So part of that is trying to have the patients ask the questions and have the patients be interested. We know they are. If we look at things like, one of the examples was delayed cord clamping. That was something that they were like real adamant about. Then the studies were done. It was like, oh yeah, that is good, right? So, but they drove a lot of the change. And I think putting the power in the patients to ask the questions is helpful. So we came up with like a little slogan, it's normal till it's not, know the signs, know your care plan. And then trying to potentially link them to resources like the ASPF podcast, social media page, peer-to-peer stories about things that have happened to them, reminiscent of the podcast and the awesome presentation yesterday, telling that story from the retrievals. And then also maybe other things like about the anesthesia process, like what it was like when I had my epidural, or what to expect, what we mentioned, what's an A-line, when would I need these things potentially, and to get more awareness. One of the big things was trying to cross-collaborate on different organizations. The AIM Maternal Early Warning Signs that's been presented multiple times is fantastic. It's healthcare literate. It comes in 90 languages. It has infographics. I mean, it reaches, you can click on it. It has more, you can ask more questions. Trying to get every society we can probably to refer to the same thing is helpful. And then looking at including the patient calculator. This is what she said. This is the radical, this is the real next level thing. But brilliant idea from one of our, he had to leave for his plane. But he asked about, like, is there a calculator patients could look at to see, or is there anything to see if, like, how much risk they have? And I was like, there is. But it's not patient accessible. But in the SMM, Dr. Main had published a paper about severe maternal morbidity and risk coming into the hospital. In our California maternity database, you can see a patient's risk of having SMM based on the problem list and the codes. And I love to look at that and see, like, if somebody shouldn't have had anything bad happen, but they're in my SMM file and it looks like it was a 2% chance of a problem, what did we do? What did we do wrong? Like, is there opportunity? Is it just bad luck? But often we find opportunity. And, you know, the highest risk is an accreta plus something else. You can get up in the 60% risk, right? So could we translate that calculator to be patient-friendly, to then have them be able to plug in? I have diabetes. I have had a C-section. I have a baby with a cardiac problem. Should I be delivering at my local community hospital, right? So that was, I thought, a really good way to also, that this group came up with, to tie levels of care. Patients knowing, like, is this really the best thing for me to deliver in remote Iowa? Or should I be going to the university center, right? Upstream thinking that way. And then, of course, over here we talked about, this is the level of care thing, outlining options for maternal and fetal reasons, potentially empowering patients to ask questions about what's right and wrong or where I should go. But doing it surrounding a campaign, and maybe we thinking like a picture on a social media, like, it's normal till it's not. And then that's like, well, what's normal till it's not, right? And then you get a click, right? So trying to bring in questions and empower the patients.
And a lot of partnering. I heard a lot of relationship partnering, not just with the patient, but with other organizations. What was that tagline? It's normal till it's not? Know the signs and know your care plan. Yeah. Not just the birth plan, but the whole care plan. So it starts far further antenatally. Yeah, I see. Got it. Yeah. And then the patient-friendly calculator. How many people like the patient-friendly calculator? Oh, that looks like it got. But surgically, do the patients get it?
No, I'm saying it exists in the surgical ward that patients have access to.
Oh. Oh, patients can get to the NISQIP calculator. Mm-hmm.
But we should have one for pregnancy. Am I at risk for preeclampsia? Am I at risk for BTE? Like, am I higher risk or low risk? Like, that should be, because patients don't even, they think pregnancy is normal, healthy. I shouldn't be sick. I'm not sick. We've taught people pregnancy is not sick.
Right. ASA 1 or ASA 2? Okay, we don't have to go there. Okay. Okay. All right. What do you want me to do with this now? Shall I hand it over to you guys? Or do you want to say what's next? You know, I think one of the big paths is this, to me, is this collaboration, the last day and a half. You know, that was really creating a pathway to smooth out all those bumps in the road and whatnot. So I don't know what the plan is in terms of continuing this path, but I think that would be a great way to continue the path. And maybe that's a good way to hand it over to you. But wait, before we do that, I think we should all give Stacy a round of applause. Where are you, Stacy? Are you still there? Yay, Stacy. Okay.
So in the spirit of thanks, thank you, Stacy. Thank you, Mike and Katie. Thanks to our AV team. Thanks to the Palmer House team. Thanks to all of you and all the folks who joined us earlier. It's been a phenomenal day and a half. There have been so many stories shared, connections made, insights realized. Even the ones that we weren't able to talk about, we will capture. So the conference team will debrief. We'll make sure that all of those ideas are captured. And usually what the APSF does, we generate a meeting report after our Stoelting conference. So it comes out in sort of stages. We try to share early learnings as soon as we can, but there will be a paper that comes out of it at a minimum, but we have an intrepid social media team as well and a communications team that's gonna help us get the word out. We wanna partner with you. So if you have ideas about how to move some of these concepts forward, talk to us. Talk to us now, talk to us in the future. We have to do this as a community of people. But what we talked about will not change unless we all take action and we take action together. So that's really what this is about, is coming together to identify the path forward. And I think we've taken measurable steps toward doing that. May?
Oh, I just want to reiterate that message and just express my great gratitude to all of you. I think this meeting's been an upper in many ways, and it's because of your contributions and your willingness to share your insights. I want to make the promise that we will continue. And we, as stated, we'll keep track of all the ideas that were shared. We'll figure out ways to disseminate and to keep the partnerships going so that maybe we can make that last mile. Elliott. Thank you. Safe travels, everybody.
Yeah, we're all done. Thank you very much. Have a safe trip back.